Thank you very much, and thanks to the organizers and especially to Leo for inviting me here. I won't thank Visha because it's always a bit difficult to go after her and debate with her. It's going to be a tough task. I'm going to do my best. Some of my arguments are probably going to be a bit, I don't know if you say that in English, fallacious, something like that, which, well, you're going to see that. Disclosures, most of them are quite relevant to the topic, but I'm going to be quite balanced. What I'm going to try to do is to answer very simple questions and answer them very simply with quite basic facts, which obviously can be always debated, but I'm going to try staying very simple. And the questions I'm going to try to answer there are four of them. The first one is, does pathophysiology help us regarding the respective effects of LABA ICS versus bronchodilation? Second question will be, do bronchodilators actually reduce exacerbation rate? Because if they don't, there is no issue. And I'm going to address LABAs, LAMAs, and combination of both. Next, I'm going to address the real efficacy of fixed-dose combination containing ICS, and then I'm going to finish by the direct comparisons between fixed-dose combinations and bronchodilators, either one or two of them. So first, beginning with pathophysiology. Obviously, we all know that the inflammation, both airways and systemic inflammation, are quite crucial in the history, natural history of COPD, both from a pathophysiological and a clinical perspective. So there is definitely inflammation, and if we want to be effective, we have, theoretically at least, to fight inflammation. And inhaled corticosteroids or corticosteroids in general are probably the best anti-inflammatory agents, the broader anti-inflammatory agents. So definitely, from a theoretical perspective, they should work. If they work on inflammation, they should work on all the consequences of inflammation, which obviously include exacerbations, and there are many, many arguments in favor of this. But the problem is that there is some level of steroid resistance in at least some, probably most COPD patients, which certainly does not mean that inflammation in COPD is completely corticoresistant in all patients. Nobody can say that. But there is some level of corticoid resistance which can explain why corticosteroids are indeed not very effective in COPD. I won't enter into the details of the molecular mechanisms which are involved in this resistance to the effect of corticosteroids, just to say that it involves some cofactors of the efficacy of corticosteroids, which means one of them is HDAC, histone deacetylase, and histone deacetylase is the cofactor which is absolutely necessary for the corticosteroids to exert their effect on the cell. So if there is no HDAC, there is no effect of corticosteroids. And when you look at smokers, and especially COPD, and it increases with the severity of COPD, you see that the level of HDAC decreases, which explains why corticosteroids don't work that well, which again does not mean that they don't work at all, but not that well. And that is why many researchers and many pharmaceutical companies, biotech companies, are developing new anti-inflammatory agents. And you can see on this slide, even if you don't see the details, all the green boxes are new anti-inflammatory agents which are currently being developed. Why are they being developed? Just because inhaled corticosteroids, who should be the most effective because broader anti-inflammatory agents, are not, again, that effective. So that was the pathophysiological part on steroids. Now, bronchodilators. One question you have to ask yourself when you deal with prevention of exacerbations by anti-inflammatory agents and bronchodilators is, why should bronchodilators or could bronchodilators prevent exacerbation? What could be the underlying mechanism? And some of them are written here. One quite simple, probably simplistic thing is that bronchodilators increase bronchial diameter, which means that they will reduce the impact of a given increase in the airway wall thickness or a given increase in the airway smooth muscle tone. The impact will be reduced because the baseline diameter is greater. So you will have a reduced impact on airway resistance and probably on the perception of breathing difficulty, which is induced by a given degree of stenosis of the airways. You can call that resetting or recalibration of the perception of dyspnea. So that's one possibility, which has not been explored a lot from a clinical perspective, but there is this possibility. Another possibility is that you will have what I call there bronchial stabilization, which is a reduced variability of smooth muscle tone, which is induced by the long-acting character of these bronchodilators. And there is maybe more pathophysiological explanation, which could be that bronchodilators could prevent bronchoconstriction-induced remodeling. And this has been shown mainly in asthmatics. And what you can see, I hope, yes. What you can see here is the effect of 3 challenges, one with allergen, one with methacholine, and one with methacholine plus bronchodilation, on eosinophilic inflammation, growth factor production, TGF-beta, and the collagen thickness, basement membrane thickness. And what you can see is that when you constrict the smooth muscle, whatever the mean you use to constrict, you will have some increased production of growth factors and some increase in bronchial collagen thickness, which means that it's not inflammation. If it was inflammation, you would have this effect on TGF and this effect on collagen thickness only for the allergen challenge, but you also have it for methacholine. So it's not the inflammation which drives in this experimental model, which drives the remodeling. It's the bronchoconstriction itself, because you can prevent it when you administer a bronchodilator together with methacholine. If you don't get the bronchodilation, you won't get the remodeling. So this is experimental evidence that bronchoconstriction could induce remodeling. So if you prevent bronchoconstriction through long-acting bronchodilation, you will prevent remodeling and you will prevent the consequences of the exacerbations or the triggers of the exacerbations. So that was a bit of pathophysiology. Now, going to the strong, robust clinical data. First question, do bronchodilators reduce exacerbation rate? Again, this is crucial to answer if they do better, worse, or same as fixed-dose combinations. Here you see some data from the UPLIFT trial. So this is long-acting antimuscarinic agent, tiotropium, and you can see that you get a reduction, which is not a huge reduction, I have to admit. It's a 14% reduction of the occurrence of exacerbations. So that means that a bronchodilator, long-acting antimuscarinic agent, is indeed able to reduce the occurrence of exacerbations. Then you can ask yourself, what's the best? Is it long-acting antimuscarinic agents or long-acting beta-2 agonist? Here you see the POET trial, in which there was a comparison between tiotropium and salmeterol, and what you can see is that tiotropium reduces exacerbation by 17%, when compared to salmeterol. So there is a better effect in that study with tiotropium compared to salmeterol. Again, it shows that there is an effect of bronchodilators and that presently available long-acting antimuscarinic agent might be better than the old long-acting beta-2 agonist. Now you have some data with indacaterol. These are data, I won't spend a long time on them because these are not the high-level data from a methodological perspective on exacerbations, because it was an open-label trial against tiotropium, and what's interesting is the prolongation of the study from 6 months to 1 year, but not all patients went from 6 months to 1 year. So it's not methodologically perfect. But what it shows is that you have, that's what you get, lost it, that's what you get here. You have a reduction in the occurrence of exacerbations, which is showed by the odds ratio. So you have a preventive effect of a long-acting, ultra-long-acting beta-2 agonist on the occurrence of exacerbations. And that's also what was shown, at least for some exacerbations, in the SPARK study. in which QVA, which is the combination of glycopyrronium plus indacaterol, was compared to glycopyrronium alone and tiotropium alone. And what was shown is that, at least for the mild exacerbations, and that translated in all exacerbations, you had a reduction with the combination of the long-acting antimuscarinic agent plus the long-acting beta-2 agonist. So there was a decrease compared to the long-acting antimuscarinic agents, which were glycopyrronium and tiotropium. So that shows that long-acting beta-2 agonists have a preventive role on exacerbations, at least on some of them. And we could probably debate for hours on the signification of mild exacerbations compared to moderate, severe, and so on. What does it mean? But this could well be due to the mode of effect of the bronchodilators in prevention of exacerbations. Third question, what's the real efficacy of fixed-dose combination? So I'm going to show you the same data, but probably the angle is going to be slightly different, obviously. This is data from the TORCH trial, in which you can see that there is a 25 reduction here in the occurrence of exacerbations between placebo and the fixed-dose combination. Okay, that's good. 25% is not bad, actually. It's probably very significant for the patients, at least for some of them. But what's interesting also is when you compare these data with the fixed-dose combination to what you have with salmeterol, the difference still is there, and it's still significant, but it's absolutely not the same range. It's a 12%. Yeah, that's it. It's a 12% reduction. So it's not at all the same magnitude. And if you ask yourself the question, what does the corticosteroid add to the bronchodilator, because that's the issue, it adds 12% reduction. So it's not that good. We know that people with COPD patients with frequent exacerbations will have poor survival. That's what's shown here. And you see that the difference between those who do not exacerbate and those who exacerbate very frequently, the difference is quite dramatic. I mean, it's a huge difference, which means that exacerbations have a huge impact on survival. And we also know that they have a very important impact on quality of life and so on. So there is a huge impact. So if you have a treatment which is able to prevent significantly exacerbations, it should prevent very significantly mortality when you look at these kind of differences. And that's where the argument is a bit fallacious. But when you look at the mortality, okay, we can debate on, we won't debate actually on the p-value, because it's not, I don't think it has any sense. I mean, it's just a question of statistics, and there is certainly some difference there. Well, I believe there is. Not significant, okay, but there is. Okay, but it's quite a small difference. Okay, it's 17.5% relative reduction, but it's 2.6% absolute reduction, which is nothing. Well, actually, I don't believe it's nothing, but I'll tell you it's nothing for the argument. And what we could conclude is that a really significant reduction in exacerbations, when you look at the previous slide on the impact on exacerbations on survival, if the product had a really significant impact on exacerbations, it should have a really significant impact on mortality. And from that data, I believe that there is some impact, but it's not a really significant impact. We can debate. When you look at where is the impact of the product on exacerbations, you have it here. When I say where is it on moderate only, or on severe exacerbations? And then look at this. You have here the effect of placebo, salmeterol, fluticasone combination. Look at combination compared to the others. Well, it's significant, a little bit, but it's not more significant than what you have with salmeterol. And there have been lots of debates and people saying that most of the effect of the combination is not the effect of the corticosteroid, it's the effect of the bronchodilator. And when you look here at severe exacerbations, that's also what you see. So maybe it's not adding the steroid which makes the difference, or at least not in the wide majority of patients. And there is the issue of pneumonia, which is a real issue. I won't debate on that. But there is a real issue because it has been shown in virtually all studies with this product, with corticosteroids indeed, that there is an issue there. So it's a question of cost-benefit. We want, not cost-benefit, sorry, benefit-risk. We want to be effective, obviously, but we want also to be safe. And the product is going to be useful, and one product might be more useful than the other if it's not only more effective, but also safe to have a benefit-risk ratio which would be more favorable. Data here with Relvar, the new combination. Fluticasone, it's not the same fluticasone, it's fluticasone furoate, and Vilantrol versus Vilantrol alone. So you have here the combination of two studies, and here you have the two replicate studies. The net, the global effect is positive. But when you look at the two studies, one is negative, one is positive. And this one is not only negative at the high dose, but it's quite strange. I mean, there was a hierarchical statistical analysis. So if the 200 dosage was negative, they couldn't do any statistics. Obviously, this statistic would be positive. But what would you conclude from that? I mean, you have the high dosage, which is negative, the low dosage, which is negative, and the intermediate dosage, which is positive. And it's absolutely not the same shape here in the second study. So it's impossible to understand what happens here. And the question is, who should we believe? I mean, which study is the right one? I don't know, so I can't conclude. And again, you have here an issue with pneumonia and fractures, which is a problem, and it's a problem because it might have an impact on death. So you have a study which shows some, I would say, non-conclusive evidence on the effect because you have discrepancies between studies, and you have also some evidence of risks which are absolutely not negligible due to the occurrence of more death in one group than the other. I will finish by the direct comparison, because the question at the end has to go to direct comparisons. We can think about theoretical aspects, studies on one, studies on the other separately, but the best evidence at the end is when you combine frontally one and compare it to the other. Again, I'm going to go back to some studies that Professor Vejika has already quoted, which are the Optimal and the INSPIRE study. The INSPIRE study was the comparison between tiotropium and combination, fixed-dose combination, and in the Optimal trial, it was a combination versus single bronchodilation tiotropium, double bronchodilation tiotropium plus salmeterol, and triple therapy, which means fixed-dose combination plus tiotropium. I won't go too much into the methodological details, because what's important in these studies, which were quite good studies, probably one is a bit better than the other, but I won't tell you more. The main point is that one. The main result, which means the result with the main criteria of assessment, the main goal of the study was negative. The main outcome was exacerbations. So when you conclude from that, when you want to conclude from that something, the only thing that you can strictly conclude is that there is no difference between the arms that were compared in terms of the ability to prevent exacerbations. There is probably something in the Optimal trial in between, which means at the end there is no difference. There is probably something there, I have to admit that. But at the end, it's negative. When you try to see if there are some patients who react more favorably to one treatment, to one arm of treatment, than to the other one, so you do some adjustments and statistics and to look if there is difference in the response in terms of age, gender, FEV1, and all the history, and you find nothing in this study, which means that there is no clinical factor which is predictive of specific response to one product rather than the other. Probably, again, a question of power, definitely. In the INSPIRE trial, you have the results here that Professor Vejika showed you. You see that there is a differential effect of the tested treatments, long-acting antimuscarinic agents, fixed-dose combination. There is a differential effect on the exacerbations. depending on whether the exacerbations you look at are those treated with steroids and those treated with antibiotics. Okay, and you can build some theoretical explanations which will explain that very nicely. But at the end, my argument, I have to take this argument, is that the result overall is negative. Here you have a study with tiotropium and tiotropium plus budesonide formoterol. That's a very nice study. When you look at this graph, you're astonished. I mean, you have a preventative effect of Symbicort on top of tiotropium, which is absolutely huge. Here you have the exacerbations on tiotropium only, and here on triple, including budesonide formoterol. It's huge. But the problem is that we have that in one study, and that's it. There has been no replication of a type of difference like this one. So I don't know what the explanation, but there is definitely something very strange. It doesn't mean that it's not true, but if it's true, we don't know why it's true in that study and not in others. Certainly some differences in the patients and so on. We can discuss that. And then you have a study with, again, it's a combination, but in this study, it's a beclomethasone formoterol combination in the management of COPD, and it's compared with budesonide formoterol and fluticasone, and formoterol, sorry. And what you see is that you have strictly here no effect on exacerbations. There is a very simple explanation to that. There are no exacerbations in that study. So you can't find any prevention on something which does not occur. But this has to lead you to ask the question, who are those people who have frequent exacerbations in the real life? I mean, who are the targets for the prevention of exacerbation, or for the what I would call the extra prevention of exacerbations, which could be provided by inhaled steroids on top of bronchodilation? And when you look at the results, you've seen that already. When you look at the results of the ECLIPSE trial, study, what you can see here, if you look at the frequent exacerbators, who are frequent exacerbators throughout the 3 years of the follow-up, how many people are there in that group? And the answer is 12%. Which means that almost 90% of the population that you see every day are not frequent exacerbators during all, they are treated. So, okay, we can also debate that. But real frequent exacerbators are very infrequent. And these are probably the target of the extra prevention of exacerbations that would be provided, as I said, by inhaled steroids on top of bronchodilators. Direct comparison between bronchodilation and fixed dose combination. That's what you get here. There is a study comparing glycopyrronium plus indacaterol to salmeterol fluticasone. And what's the answer? Again, the answer is here. You see COPD worsening. It's a 6-month trial. Exacerbations were not a primary endpoint. So it's only as COPD worsening that where you have the exacerbations. And what you can see is that there is no additional effect of salmeterol fluticasone compared to QVA, the double bronchodilation. Again, patients did not exacerbate a lot in that study, and they were recruited in that study because they didn't exacerbate a lot. So they were not a specific target for prevention of exacerbations, which means that in these populations, which probably corresponds to all the others but the 12% of frequent exacerbators, all the 90% of the population is there, no additive effect of steroids on top of bronchodilation. So to conclude, what are the answers to the 4 questions I asked at the beginning? From the pathophysiological point of view, we have inflammation, but this inflammation is not that sensitive, or is probably quite a lot resistant to corticosteroids. We know that bronchodilators reduce actually exacerbation rates, and there are many, many studies showing that, and that's true for long-acting beta-2 agonists, long-acting antimuscarinic agents, and combination of both. We know that fixed-dose combination have some effect on exacerbations. I won't say the opposite, obviously, but not that much. I mean, the effect of fixed-dose combination, and especially of the steroid component, is not huge. And when we look at direct comparisons between bronchodilation and fixed-dose combination containing steroids, well, I believe that the evidence is not that conclusive and not that robust in favor of fixed-dose combination. So what do we need in terms of anti-inflammatory agents? We probably need other anti-inflammatory agents than steroids due to this resistance phenomenon and so on. But certainly what we do need is a better characterization of the target population of maximal prevention of exacerbations, which means triple therapy plus or other types of treatments and anti-inflammatory treatments which are going to arrive on the market. And certainly, I believe that the future is there. It's the better characterizations of those who really need prevention of exacerbations. Thank you for your attention.